Okay, so next up we have a 41-year-old gentleman, smoker, had an inferior wall MI, mild LV dysfunction. His RCA has, PAMI to RCA has been done already. Next up we have his LAD which shows 90% lesion in the mid part and proximal circ and OM. Our plan is to stent LAD and LCX-OM bifurcation followed by IVUS evaluation.
Dr. Samir, you're on.
Thank you. Okay, ready? Let's see. So we have an EBU, 3.5, 6 French. Let me just see, just 1 second. Good, okay. Let's do a AP caudal first and see. Ready? Record? Yeah. Good, okay. And let's do a cranial, AP cranial. So we have a 2-vessel situation here, LAD and first OM. Ready? Okay, record. Good, okay. So let's wire with our, we'll go after the LAD first. BMW is good, yeah, that's fine.
So Samir, what are you thinking about? Primary stent or pre-dilate?
I'm going to pre-dilate because there is a little, as you can see, angulation there in the LAD lesion. And we want to see what's going on over there. So you can even make an argument to do IVUS first, but we'll pre-dilate first with a balloon. What do you think is the size of that LAD panel?
I am actually from the angle, so I undersize it, but Kintul and Tak can 12 better.
Yeah, I think
because artery looks small from this angle here, where I am sitting.
It's proximally at least 3.0 vessel and distally at least 2.75.
Yeah, I was
it might not be a bad idea to IVUS, particularly for academic purpose. That angulation may have more calcium than we can see on X-ray.
Yeah, that's why we worry when we see
Okay,
the
do we have
angulation like that.
Do we have the IVUS ready? Prof, sir? That's good.
Your PMWI?
Yeah, BMW, yeah. Just a second. Okay, so let's IVUS and see what size and what characteristics of the plaque, etc. We're getting the IVUS, and I think before we plan to IVUS, I was going to pre-dilate with a 2.5 balloon and then see what it looks like. But I think IVUS is not a bad idea. We're waiting for the IVUS to come. So most of the time when there is this kind of a bend, the LAD could be intramyocardial in that area also, which will obviously affect the expansion characteristics. Fluoroscopically, we are not seeing much in the way of calcium. About 2.5 by 15 balloon light, Ajahn.
So I think this question was asked before, but Sam, you were not there. What percentage of your cases you start with imaging if you already are committed to treatment? I'm not talking about physiology.
So as far as the imaging goes, I usually don't do any pre-imaging unless I'm very unsure about the size or if there's a lot of tapering or discrepancy. As far as the physiology, we do that very frequently, for the obvious reasons to establish lesion significance before we go intervene. How many of, if you can ask over there, what percentage of people do pre-IVUS in their interventions?
So can you please have a raise of hand? How many of you use pre-IVUS in more than 25% of cases before treating the lesion? I guess not a single person, 0.
And how many of you size 1-to-1 based on the IVUS size? Whatever you find on IVUS is what you pick your size. Or do you average with angiogram or use some in-between hybrid formula?
So I personally generally hybrid formula. I do not go by IVUS sizing. I would kind of use the angiographic experience along with the IVUS imaging.
It's true. And one of the most important reasons for that is because IVUS is frequently affected by artifacts, especially the non-uniform rotational deformation, the NERD artifact, which one has to be very careful because it grossly oversizes if you go 1-to-1 and you end up with mechanical complications.
And we also tend to, it tends to take the consideration of the positive remodeling, and if you really go aggressive in expanding the stent, you might be causing more inflammatory response. So the experience is that whenever I use a larger stent and IVUS guided, post-dilated more aggressively, they had more chances of stent thrombosis than not.
Very true.
Samir and Kintur, in altered RFT when there is borderline creatinine, have you done angioplasty on the basis of IVUS only? So you can use only few ml of dye when there is altered creatinine is altered little bit.
So
we're not able to hear you guys here very well if you guys are talking to us from the auditorium.
So the question was that do you do intervention just primarily based on the IVUS guidance to limit the contrast use? And personally, I have not done that. I'm very, very cognizant about the contrast use whenever patient has significant renal insufficiency, count every cc of contrast injected, and you kind of be very cognizant about minimizing the contrast, but I haven't done IVUS guided only intervention.
Yeah, I think, even Paul Tierstein, who has written on it, the 2 times that he absolutely gives contrast is when he has, after every inflation, and just to make sure there is no perforation. And, Paul has described cases where he has used less than 5 ml of contrast. Right, just a second here. It's fighting me a little bit because of the TUI. I think I'm doing something awkward here. Good, okay, I'm good now. Yep. Saras. But yeah, contrast use can be minimized, and I personally feel quite uncomfortable doing intervention completely based on IVUS. Okay, I think we'll start from there and do automatic pullback. So where is our IVUS? Can you guys see the IVUS console on your screen? The screen, I mean.
We did not see the imaging. No.
You're not seeing the image?
No.
Okay. Can we show the image to the audience from?
Yeah, we see it now.
Oh, good. Okay. Excellent. Okay. Now we should. Oh, okay. Should be entering the area there of the dive of the LED. Oh no, we're back already in the proximal. Okay. Okay. Okay, we could stop there, I think. Yeah? Stop. Good. Okay, now let's replay and see what we got. I'm going to bring the catheter back. Just 1 second.
So Sam, what will be the minimal luminal area that you will stand that LED?
Depends. Let's see what it is. Let's see the reference lumen diameter. So play that, please.
Let's say vessel is 3.5 millimeter. So.
Okay, so if your media to media is 3.5, right?
No. Artery is 3.5 millimeter in diameter. So what will be your MLA that you would stent it?
So MLA is, area is 2 pi r, right? Or that's actually the circumference, pi r square. So you divide that, diameter by 2 multiplied by pi, and that should be your area. That's the expected area that you aim for. If you're going to go with the IVUS school, then that is the way to do it, is to say, okay, well, this is my diameter. I'll calculate the radius and then the area, and that's what I would shoot for. So, guys, can we get a measurement of our vessel right beyond the lesion, distal to the lesion? So let's play the IVUS.
I think the IVUS jumped through that tortuous segment.
Yeah, I think it did actually jump quite a bit there. So
Did not quite see the calcium. I don't see much.
I don't see much calcium.
Now,
Okay, let's measure. Let's see what the diameter is from 12 o'clock to 6 o'clock. Right there. So I see almost a 3.2 or so vessel from 12 to 6 just by eyeballing it, and we will measure that.
so in
So
comparison,
you think that if that red tracing is true lumen, you think it's hemodynamically significant stenosis?
this is the reference vessel.
The
so it's not
significance,
a-
I don't usually go significance measuring by IVUS anymore because, we have better means, and we've already decided here that the lesion is significant based on the angiogram wired through the partial.
I think, in this IVUS image, we are not seeing the plaque burden that we are seeing on the angiography. I'm not sure if we really captured the disease area or not. If it
Yeah,
jumped
it
through
could
what
have
the
jumped through
artifact was. And this is the proximal reference vessel, so this is not really the plaque we are
Puff
treating.
there. Okay, so come back
Yeah,
a little, right?
I think the
Puff
catheter
again.
jumped.
Yeah, catheter jumped through there. So I think we will inflate there. This is a 2.5 millimeter balloon. We have a 3.2 reference area, diameter. And you can see 2.5 looks very good size there, angiographically. Okay,
Can we
down.
see the X-ray image
We
now?
don't see that. Oh.
Okay, now let's take a picture. Ready? Okay. So lengthwise, what do you guys think we should put? This is a 2.5 15, right? Or is it 12? 12. So this is a 12 millimeter balloon. I think a 15 will be a good length. It'll project a little bit further from the diagonal.
If you want to cover this distal lesion,
Yeah.
Or even a
18.
little longer.
I would go from the septal to the diagonal. And I'm going to start out with a 2.5 stent, and then we will bring it up to 3.2 with post dilatation.
So can I
Take a
argue
picture.
to use a little longer stent, Sam?
Yeah.
How
Is there
long
any
would you say?
disadvantage? I would say 18 or 22.
18?
Yeah.
Okay.
Yes, you are right. Kintu.
I could live with 18, yeah. I think 18 is a good idea because there is plaque even beyond the diagonal there, significant plaque. Good, good. So 18 is good. I think would you recommend starting with 2.5 or 2.75 18?
Took a picture.
I would go 275
275, yeah.
because our
Puff there,
vessel
just a
was
little.
big enough.
Let me engage just a little.
This
Okay,
tally
puff
does.
there. Just a little. Good.
Yes.
Okay, ready?
Yeah.
Picture?
Okay.
Good. Okay. All right. So yeah, let's take a 2.75,
By 18, 20.
18 or
18 is all
22. What do you want to take, Rajni?
20, 22.
Yeah, give me a 2.75 22, please. We'll go with a longer stent, looking at the angiogram.
So we see that disrupted plaque with the ballooning, and I don't think we saw that on the IVUS at all. I think our IVUS jumped.
I was jumped through there, yeah. And I think that's one of the problems with the intramyocardial portions is that the plaque is smooth, and so there's a lot of sliding. We see that even with short balloons. So Tejan, going back to your question about the area that you shoot for, according to John Hodgson's teaching from IVUS, he recommends that you get your distal reference diameter and then calculate area from there and stent according to that and then make your area that much at least.
And if you want to use IVUS as a guidance to treat the lesion or not, then MLA for LAD would be 3 to 3.4 millimeters square.
Actually, they published it nicely depending upon the vessel size. If it is less than 3 MLA different, 3.5 MLA is different, 4 MLA is different.
Back a
back.
little. Okay.
Yeah, take a
Ready? Puff a little.
Okay, that's fine. Take a
Right.
picture.
Let's take a record.
Little goes little.
Right. I think that's decent there. That's decent, right?
Yeah.
Yep. Ready? Okay. Let's go up.
What stent is that?
It's the Osirio Biotronic stent. How much are we in?
12.
12. 14 switch over later.
Yeah, 14.
Okay, good. Okay, down.
$2.97.
So in air, this stent should have been 2.97. And we'll see what it looks like now angiographically. Ready? Good. Okay, came out decent. Now, since we got a 3.2, minimum lumen diameter there, I would take a 3.0 NC balloon and we will dilate this up to higher pressure. We have a 3.0, 12, 15, whatever we have. Yeah. Excellent. That's perfect. That's perfect. Thank you. 3x15 NC track.
So do you have a routine that you use your NC balloon at particular atmosphere, or do you really decide based on whether you are sizing 1:1 or less than 1:1?
Yeah, so I have gone mostly to observing the balloon growth on the screen rather than going to certain atmospheres. And then if I am not worried, then I would at least like to go to 14 and preferably higher. Because as you can see over there, angiographically, we already have a step down. Let's go over there. Yeah, I think.
Take a scene.
Let me just see.
Oh.
I think this is a good place to start. Yeah. Good job. 3, 12, and 14.
14. Okay.
Good. Down. Good.
Back.
And haju ek pachhad. Okay, just 1 second. Okay.
So Sammy, either 5-second invasion
Little
or
bit.
40-second invasion.
Now I go usually 10, 10 second plus is my minimum.
14.
Chauthi hai na bra, sir.
This goes
Okay.
up to the 3.0.
Good, perfect. Okay, down. So, saras. So,
I think longer invasion is better.
yeah, longer.
But most of the time is we are not the patient.
Yeah, well, according to Luard's data, at least 12 seconds. I think that's pretty good. What do you say?
I think so.
Looks
Yes.
great.
Do you guys look okay? Yeah, I mean, you guys feel okay. So then we have a 3.0 balloon, so I'm going to bring it out because the circumflex is clearly not 3 millimeter. And we're going to switch to circumflex now. And very nice.
So I just joined you here, Sam.
Yes,
So what wire are you using there?
this is a BMW,
Uh-huh.
a short BMW. And
Why did you choose a BMW?
that's what we had, but there was no specific reason for that. Let's go AP caudal and I will.
Is that your
we just,
workhorse
wire
wire in
the
general?
circumflex now, right? AP
Sam,
caudal. Pardon?
Is that your workhorse wire in general?
I use Pro Water now as my workhorse.
Okay.
I have switched from run through to Pro Water.
Why?
That's a long story, but
It's cheaper.
I knew it was going to be an interesting story, so.
yeah, I had a few wire perforations from the run through.
Oh, really?
Yeah, it was surprising. I never would have expected that, but I did.
So the Pro Water and the BMW are my two workhorse wires, and sometimes I use them for bifurcation because they have different colors.
Huh?
So it's easier to identify which wire is which.
Door cut off. Yeah, I used to love the run through. Puff cut. Think we did.
Is that because the tip is a little bit aggressive, or?
I thought so. I thought they made a change. I asked Rumo personally, and I was reassured that no change was made. But obviously, it felt like there was a change. So let's take an angiogram here. Ready?
No, I agree with you that tip actually with the newer wire is a little bit stiffer. So
Right.
I always break it.
So now,
And-
yeah, you're right. I was doing that for a while there, breaking the tip. Now, I'm actually going to go here without wiring the bottom branch and just put the stent right at the ostium of the OM, right? And we have a 2.5 balloon open, but I want to go smaller. So give me a 2.0 by 15 balloon, please. Pressure?
I think that's a good
Looks
idea.
like you're in a room to
Yeah.
nail the ostium.
Yeah, exactly. I think we can nail the ostium. The circ magnifies, and so we will go, a little bit lesser than what we normally do.
But I think that even if you stent across that
Branch, it'll be okay. Yeah, yeah.
if
2
you
point.
stent across that
Yeah, 2 point.
you'll be
Yeah,
fine.
yeah, 2. Yeah, we can jail it. I don't think there'll be a problem.
Because you don't have much plaque in the OM that you can shift towards that.
That is
distal
true.
circuit.
Yeah, most of the OM
So I
plaque
think you'll be
is
fine.
actually towards the LAD.
Correct.
Yeah, it's superior as we call it.
Yeah, it's superior, and then it's you have a little knob there that doesn't have significant plaquing. So
Exactly.
I believe that everything's going to be okay. Just keeping it simple.
Circ no wire जो पाछो ना आई जाए.
Yeah, it's okay.
अच्छा.
So what's the plan?
So we're
Stand
gonna
across or just you do the ostium?
I got wire here. Actually, we'll just try to nail the ostium directly. Just put the first strut at the very ostium of the OM.
So if you were not committed to,
Puff.
intervene here in a live case in your lab, would you have
Okay.
done a physiology evaluation before taking this
Not
decision?
for this, no. I think it's pretty, tight enough. Okay, ready? Ready, let's-
That's nice. Yeah.
Yeah. The one thing I've learned about the FFR in the circumflex is it's very frequently negative, even when the lesion is quite significant.
That is because FFR does depend on the coronary vascular blood it's
Exactly.
perfusing. So
The myocardium that we have distally.
That's fine.
Okay, so that looks good. So stent wise, I would just take a 2 1/4 stent to start, and then we'll dial that up. So 225. This is a 12 balloon. We'll take a 225 12 stent,
Yeah.
and 225 12 stent, please.
Is that a 12 millimeter balloon?
Yeah, that's a 12 millimeter.
Are-
balloon.
Don't you think that that's going to be too tight in terms of length?
I think we'll be okay. I think we do have some distal room,
Okay.
even with this balloon.
Let's show the picture again.
Yeah,
one
play that last
with
picture,
balloon.
please.
Let's-
And as you will see, stent will always look bigger than balloon.
Always, always, yeah, always. કેવું છે બધું રક્ષિતભાઈ બરાબર હા એકદમ બધું પરફેક્ટ ચાલે છે ચિંતાનું જરા 1% બી કારણ નથી
If that's a 12 millimeter balloon, I think
100% good.
12 millimeter length. Sam.
બસ હવે બધું બરાબર ચાલે તો 5-10 મિનિટ પતી જશે પણ એકદમ સરસ ચાલે છે.
And this is a biotronic stent. Do you have much experience with those with the biotronic stent?
No, I have never actually used it. I have heard of it, and I think it's going to come to the US, but
And what's the drug on them?
yeah,
Sirolimus.
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 Sirolimus is
Okay.
what I'm. Yeah.
That's a good drug.
Sure.
In the States,
Why
we
I
don't
did
have much, all the variety of stents available in India or in Europe. So we only have major companies. We have Abbott, Medtronic, and Boston Scientific drug-eluting stents.
Just a second. 1 minute. Let's do it, cash. Let's puff.
Go.
Go in, right?
I think the length is going to be just perfect.
Yeah.
And,
Ready?
and
Picture?
the 2 balloon looked very good in size.
Oh, perfect.
I think that's a good spot, right?
Yeah,
Looks very good there, Sam.
we go ahead.
So Sam, why is that actually? 12 millimeter balloon and this tent looks like 18 millimeter, even though it is 12 millimeter.
I think from your angle, no?
Go ahead.
Well, because
From here it's okay.
because the markers
Good
in the balloon are 12 millimeters exactly, and here the markers are like 1 millimeter away from each side of the stent, which is
Just
the
1
stent
second.
actually 12 millimeters.
પાછું લઈ લેવાના.
So that's,
અને puff
that's
કરજો
the
ને ત્યાં
reason
જરા.
why I think it looks a little
Perfect.
longer.
Ready?
It's good.
Okay, looks nice. What do you say?
You pinch
Now
a
this was a
little bit.
2 1/4. So you know what? Give me a 2 1/4 short NC balloon because we went to low pressure with this, and I would never want to leave the stent at low pressure.
And maybe FFR, that distal circ, make sure it's not pinched.
No, there is very little myocardium there, Tejan, so I will leave it alone.
FFR of the OM1 would have been negative also.
Yeah, even if it's positive, I think
You think your stent protruding a little bit to the main circ?
probably is. Yeah, probably is. But I wouldn't worry too much about it. Let me get a 2 1/4 by 8 or 9 short balloon, please.
2.25 by 8 balloon.
Yeah.
That's why all the debate is when we stand the ostium, sometimes a much better stand across the lesion. It's a much better.
Saras.
Take a picture last shoot.
Yeah, picture.
Last shoot runs.
ना बराबर side में रहा दिया वो नानकड़ी है भी जाम तो
It's okay. No?
yeah, and it looks not bad at all. Yes, yeah, side branch is good. I think there is some stained gel appearance, but it looks good.
Looks very nice, Sam.
Yeah.
And then you have a
Yeah.
step down into the distal vessel.
Yeah,
So I think
we
you gotta-
deployed the stent at 6 atmospheres, so I want to make it to 14 so that we have good
We have a
high pressure.
2.25, 10.
10 later, 10 bravo. 10 is good. Anything shorter than 12 is good.
So they're giving you a Tazuma balloon.
Tazuna is a Terumo. Very good balloon. Yeah, Terumo balloon.
It's a non-compliant Tazuma, and the nominal pressure
You know,
is 14.
I thought, Samir, that Tazuna has 2 millimeter has a single marker.
I don't know
So
the
this one is a
primary
single
details
marker.
of
You
it
are
now.
absolutely right. So
But
it's a
then
10 millimeter
the
with a
one
single
that
marker.
they just used it had a 2 markers.
This single
I don't know if you
single
wanna
central
focus
marker,
here.
na? Whatever.
So we're gonna give you a snapshot of the box of the
Right,
the
but
balloon.
can you look up a bigger balloon like 15 or something? Is that 2 marker or 1 marker?
This one is
There you
one
go.
marker,
Can-
it's a
can
10
let me-
millimeters. So I think it's going to be okay because you're going to concentrate the force, the
Okay.
radial
Barabar, jo- jo,
strength of
picture
the
lead
balloon wherever you need it the most.
Okay, that's fine.
बराबर है ना अल्लू बराबर लो चलो
And you can go all
Okay.
the way
किला है,
to
14 સુધી લઈ જાવ એટલે.
259.
excellent down good
Looks
Okay.
beautiful there.
just a second okay puff अच्छा लगा दी चलो
Just
perfect okay very nice everything came out okay sir costume is good we'll pull wire and let's
Round
take
of
a
applause
wireless
to Dr.
picture
Pancholy there.
let's take no it was a come on ready चलो एक picture ले लिए
Okay.
चलो ready record okay good and now let's do one cranial make sure LED is still good.
So Tejan, what do you think of the lower branch?
Time to go for lunch.
Perfect. Okay, chalo, saras. Let me come out. Good. Okay.
Yeah, excellent, Samir. Excellent.
you, thanks,
So
thank you.
I think it's a time we will be preponing the lunch, and we will be assembling maybe by 2:15 for 2 lectures. First by Rajiv Gulati and second by Professor Akashi Takasaka, and then we will be continuing live cases throughout till end. Okay? Thank you.